Calitra, which they threw at it, and it did not seem to work after trials, no difference to what they've called traditional Chinese medicine, and to, of course, hydroxychloroquine and different medications, including steroids. Another thing that quickly came out was that a lot of these patients affected with COVID-19 would also develop blood-borne pathogen infections like Staph aureus, Aspergillus, Klebsiella, and E. coli, which were susceptible to antibiotics. So just cutting to the chase, the sex of each triangle is supposed to represent the least amount of weight being given. So in medical science, we make decisions on is an intervention going to work in the lab? Does it work in animals? At this point, even if it does, it is not enough reason to translate that science from the bench to the bedside. It has to go through some studies. Next is where you have no design. So I decide I've taken care of, seems to have worked, but I really didn't do any design. I did not compare it with anything. If I write up about this, is it enough to convince the whole world community to accept my drug X, you know, from a purely pharmaceutical perspective? The answer is no, because at that point, the evidence is only at a level 5. And then you have case report or case studies. Again, this is not enough to convince the world. And so you come to primary studies where you have case control studies. Retrospectively, subjects have the outcome of interest. They already have COVID-19. And then you go back to see what seems to have worked. That is even still at a level 3. Then you take level 2, the cohort studies, where you do prospective studies. Cohort has been exposed to a risk and you observe for outcome of interest. But then your gold standard is really a randomized control trial, which is the real experiment we all learned when we were in high school. Intervene with something and see if, without all other factors, this is going to make a difference. And when you have several of these put together, you can do a meta-analysis and then come out with clinical practice guidelines. Now, because this pandemic is so new, there's so little done on which methods are going to work, we're still trying to pick the needle from the haystack at this point. And so here is where I introduce the virus. There are over 36,000 viruses that infect humans, plants, and animals, including bacteria. And there are 71 virus families. Only 21 of them infect humans. The coronavirus comes from the family of Coronaviridae. It's an enveloped, positive sense, single-stranded RNA genome with helical symmetry. This is one that I drew myself to show you the RNA in the middle and the pink representing the spikes. It is a beta coronavirus, and it is these pink spikes that it will use to attach to the angiotensin converting enzyme 2 receptor, which is found on the lungs, the brain, the heart, the small intestine, kidney, and also to the skin. It is unknown to man. Its homology with the SARS virus is 70%, with 96% similarity with the bad virus. So in 2005, the Journal of Virology published a paper by these scientists suggesting that chloroquine is a potent inhibitor of the SARS coronavirus. Now, this was 2005 after the SARS outbreak and not the SARS-CoV-2. One of the things they found out quickly was that pre-infection with chloroquine treatment can render viral-6 cells refractory to SARS-CoV-1 infection. And this was even more effective the higher the concentration you used. However, to obtain equivalent antiviral effects, a higher concentration of chloroquine was required if the drug was added 3 to 5 hours after absorption, which meant that there's a really short window of opportunity to intervene with chloroquine. In 2020, scientists also published in the Clinical Infectious Disease Journal that hydroxychloroquine was found to be more potent than chloroquine with a better EC50 of 0.72. And based on this, the recommended dosage was 400 milligram twice a day, followed by a maintenance dose of 200 milligram twice daily for 4 days for SARS-CoV-2. Now, the question is this: if all of China hadn't thought about chloroquine, hadn't thought about Calitra, and all these other interventions. The question is, would we even be discussing hydroxychloroquine at this point? I don't know. But I'm going to just present 3 cases, and then we'll still go back to the bench to bedside. So we're going from the bench, and now we're at the bedside now. So I present a 48-year-old gentleman who presented to the hospital with fever, cough, muscle aches 2 days before, had gone to an emergency room and had been told he had bronchitis. He denied any sore throat or shortness of breath. He stopped smoking in 2002. Otherwise, he had been healthy. In the emergency department, he was quickly noted to have a fever. His blood pressure was fine, and he really wasn't desaturating. His auscultation of the lungs revealed minimal bronchi at the base of his lungs, and he had the lymphopenia, which has been known to become one of the classic features of COVID-19 infection. His test came back positive, and at that time, hydroxychloroquine was not in very common use. And so he was not placed on hydroxychloroquine. He had high-grade fevers throughout his hospitalization. His chest CT scan showed an infiltrate on the right lung. After being in the hospital for a while, he was not deteriorating. There was not much we were doing for him, and so he was discharged home. But this case demonstrates one of the features of COVID-19 management, that sometimes you don't really have to do anything. The patients will still just be fine. This was one of the moderate cases of COVID-19 in that he had a infiltrate on his x-ray. He had high-grade fevers, but apart from his lymphopenia, he really was not deteriorating, and he seemed to be hanging in there fine. It also illustrated imported case. And I'd just like to mention at this point that at least in Africa, a lot of the cases have been asymptomatic. And even in general around the world, only about 5% of patients who progress to the point of illness that requires hospitalization. Up to 47% of patients tested on several ships and enclosed spaces have been found to be completely asymptomatic. And if it wasn't for the test, they would not even know that they have symptoms. It seems to suggest in a way that not every COVID-19 patient requires an intervention. The second patient I present is another patient who was given hydroxychloroquine right from the onset, and let's see how she came along. So she presented after being home for over a week with symptoms. However, she came because she was now vomiting, had nausea, and she was so short of breath, she could not breathe. Her lab work showed mostly an abnormal C-reactive protein. Hydroxychloroquine was started right at the beginning, and you can see her fever curve was going down. However, on day 8, something unusual happened. If you can tell from these chest x-rays, she started complaining of chest tightness. If you compare these 2 x-rays, she had more of an infiltrate in the upper zones on the right and worse on the lower zones, and even an infiltrate on the left side. So clearly, in spite of being on hydroxychloroquine, in spite of being on antibiotics, she was still getting worse. And so on the 5th night, which should have been her last dose of hydroxychloroquine, she pretty much refused to take the medicine. And these were her EKGs. This were her initial EKG on the first day of presentation. On day 8, her QT interval had increased to 773. And I just plotted this to let you see how her QT interval changed over time. This was day 2 of the first day of using hydroxychloroquine. It went up a little. By day 8, it was increasing. That was the night she refused it. By day 9, her QT interval had prolonged to 773, and it came back down. But it tells us that a lot of these medications we use are not without side effects. As you all know, as lecturers in pharmacy schools, that QT is an important measurement because it can lead to torsade de pointe, which is an abnormal rhythm which can lead to life-threatening ventricular fibrillation, which can lead to death. And so using hydroxychloroquine is not without any side effects. The thought has been that anybody who has a QT interval of more than 500 milliseconds should not even be put on hydroxychloroquine. In much of Africa, it does not appear that we have the luxury to be able to do this, but in the US, it's quite common for any patient who was going to be started on hydroxychloroquine And there are some risk factors which have been noted in QT prolongation, including female gender, low heart rate, hypokalemia, and hypomagnesemia. So in a way, based on her female gender, she had a slight risk
بلا
of
كتير صح؟ بلا كتير؟
QT prolongation. The point that this illustrates is that this patient had also gastrointestinal symptoms, that COVID-19 is a multi-system disease. At this point, we know that it can cause strokes, skin abnormalities, abdominal pain, kidney failure, and multiple other problems, including liver enzyme elevation. In this patient, the
تايم
hydroxychloroquine
بروف.
did not seem to have any effect on her progression of pneumonia. And the last patient I present unfortunately died, but her case also shows a very dense bilateral lung infiltrate. She was placed on hydroxychloroquine from day one, and you can see a very high fibrinogen level and elevated D-dimer, which also represents the coagulopathy associated with this illness. All her respiratory panel was negative. It was only her COVID-19 test which came back positive. So where are we with the evidence so far as going from bench to bedside? At least we know that animal studies showed without any shadow of doubt that hydroxychloroquine or chloroquine should be able to inhibit SARS in vitro at the bench. But what happens when you take it to the bedside? There are some case reports it works. Some of the patients
Excuse me,
have,
Prof. We are
yeah.
out of time.
Okay. All right. So I will end at this point. So far as treatment is concerned, the verdict is still out there. At this point, the only thing that has been shown to work or at least reduce the death rate is dexamethasone. A lot of vaccines are in trial at this point, and this leaves room for more research that whenever you have a new disease, we're going to have to quickly dig into our bench, which is our laboratory studies, to see something that could potentially transfer to bedside. Thank you very much.
Thank you, Prof. Bertha. And excuse me, if anyone would like to give a question, you can write it in the chat box. And thank you for the very interesting presentation. And most of the attendee asked to have this presentation, so you can manage that with our organizing committee if you can share it with them. And now, Professor Sarah Agabur, Her Excellency, the Commissioner of African Union for Human Resource and Science and Technology, will join us, and we would like to thank you, Prof. Berta. And now we will move for Professor Sarah Agabur as we finally get the connection with her. Your Excellency, Professor Sarah, are you there? Professor Sarah Agabur from Cameroon. Yes. Prof. Berta, can you please turn off your video camera? Thank you. Can you unmute your mic, Professor Sarah? Thank you, Your Excellency. I know how tight your schedule, and thank you for your interest to join our conference. And by the way, the conference is broadcasted right now on the EEU TV, the Association of African Universities Television.
Okay, thank you very much. Can you unmute me? Okay, thank you very much. Thank you very much, my Professor. I'm so sorry, I was in another virtual meeting. Can you hear me now?
Yes, Prof, we can hear
Hello,
you.
can you hear me?
Yes, yes.
Okay, esteemed participants, distinguished ladies and gentlemen, I greet you good afternoon here from Yaoundé. on this first pharmaceutical and medical sciences in mitigating COVID-19. On 30th January 2020, the World Health Organization declared the coronavirus COVID-19 pandemic as an outbreak that constitutes a public health emergency of international concern and immediately called for the activation of various responses and rolling out unprecedented strategies to curb the spread and contain this pandemic. The global statistics of cases and fatalities began rising rapidly, and the disease was spreading fast and with dire consequences on the health systems and the socio-economic outlook of many countries. While African countries showed relatively lower numbers of confirmed cases at the beginning, there was, however, a significant rise of deaths due to the COVID-19 and serious social, economic disruptions and consequences. Our level preparedness, response capacity, and the state of our health systems were put to test. Thanks to the African CDC, in collaboration with regional and national CDCs that mobilize a formidable support domestically and internationally to empower our countries to face this global pandemic. As the lockdown took toll all over the world, our institutions, medical universities, faculties, researchers, and pharmacy professionals faced this formidable challenge as they performed frontline duties, providing services and looking for solutions. Pharmaceutical and medical sciences in mitigating COVID-19 has been on the center stage. There was an emergent expectation from the society for rapid and strong responses from science, technology, and innovation to address this deadly pandemic by providing surveillance and cure, as well as understanding the underlying local epidemiology and natural history of this virus through medical sciences research. Research and innovation is critical in our fight against COVID-19, and there is an urgent need to empower the African scientific and research community to lead efforts to set locally relevant scientific agendas to provide solutions for A, diagnosis, B, therapies, C, vaccines. I recently hosted a webinar for women in science as a way to mobilize our researchers to join the entire world in the co-creation of knowledge and generation of cure for COVID-19. Scientific research in communicable diseases and vaccines should be vigorously promoted
دكتور
if we are to
محمود هو اللي
develop
هيقدم
new
دكتور
medical products
قولي
and
له
tools
زودي روح.
for prevention and treatment. We should reinforce the linkage between health, research, and intervention actions, better coordinate the response. We should formulate policies to set up appropriate R&D infrastructures and facilities such as mobile laboratories and clinical trials to effectively deal with outbreaks and pay special attention to rural communities. Yes, we need a collective and effective research and innovation response based on a functional system of science, technology, and innovation on the continent that is built on strong transnational collaborative platforms that utilize our diversity, range of existing capacities and expertise while leveraging strong international partnerships, including with the World Health Organization. We need to go further and unlock the potential of local medicinal plants and traditional knowledge in order to provide a mix of responses to deal with pandemics and in particular combating the current COVID-19. About 75 and 80% of Africans use plants and traditional medicine for their medical needs. It is in this wise that this first meeting on pharmaceutical and medicinal science is very important because we need to know the right medication I was opportune to listen to the last speaker, where we are speaking about hydroxychloroquine and COVID-19 and to mitigate COVID-19. So it is for this reason that I support and I congratulate you for organizing this particular webinar. Intra-Africa collaboration is essential and key. If Africa is to win this race against COVID-19, currently a lot of work is going on in different member states and different research institutions continent-wide. But with minimal collaboration among our research communities, laboratories, and regional economic communities, we should bring on board the private sector and create PPPs and boost innovation, in particular for the production of personal protective equipment and medical supplies and preventive systems. Following the adoption of the African Union Agenda 2063, with the vision of an integrated, prosperous, and peaceful Africa, driven by its own competent and skilled citizens, able to play in the global arena, the Commission ensured that the framework is underpinned by science, technology, and innovation to foster building a sustainable, integrated R&D and innovation ecosystem that is crucial for unlocking potential solutions that address their continent's development and emerging challenges through the implementation of the Science, Technology, Innovation Strategy for Africa 2020. CISA 2024 aims at promoting the deployment of science, technology, and innovation in the areas of agriculture, health. It explores and identifies opportunities to enable member states to leapfrog the technology gap using the huge and unparalleled technological advances through mutual partnerships and collaboration in emerging technologies, space science, as well as Africa's biodiversity and indigenous technologies. The Science, Technology, Innovation Strategy for Africa 2024 calls upon member states and regional economic communities to research and innovation, infrastructure and facilities, build technical competencies, promote innovation and entrepreneurship, and create an enabling environment. It is very important for us, and for this reason, I want to say that I celebrate with you, and I also congratulate the distinguished participants who are participating with us in this first International Pharmaceutical and Medical Sciences Conference on how we can respond
Prof. Sarah, are you still there? I think we lost Professor Commissioner Sarah Agabur. So, Prof. Mahmoud Siddiq.
Thank you very much, Professor Sarah Agabur, for nice presentation. And now we call Professor Mahar Rabat former Minister of Health, special invite to WHO General Director for COVID-19.
Well, thank you very much, Dr. Siddiq, for the introduction. And Your Excellency, Professor Dr. Awad, Dr. Mohammed Mahrasawi, colleagues, Dr. Tariq, Dr. Mahmoud Siddiq, Dr. Amani, Dr. Mohammed Abdel Malik, and Dr. Rabia gives me great. Supporting healthcare heroes is really inspiring, and it makes us all rise with respect and honor to our frontliners who are really working under very difficult circumstances just to give us the security and the safety in this response and the containment of this pandemic. So briefly speaking, and I don't want to be repeating many of the issues that my colleagues have previously mentioned. So in January, the COVID disease caused by the SARS-CoV-2 virus was declared a public health emergency. With fewer than now, after 8 months, and on the 1st of September, or rather on the 31st of August, we have close to 25.5 million reported cases and around 850,000 deaths globally. Needless to say that globally the pandemic has unveiled and unpacked challenges in the emergency preparedness and response. Not only this, but as well to people, communities, rapidly changing needs and demands, and to the marked socio-economic disruptions that affected the whole world. So, this pandemic has underscored the understanding of the complexities and interrelationships among distinct determinants of the response faced by countries in their adaptive abilities and their adaptive response. And now is the time to step back after 8 months of the pandemic and rethink what needs to be done to get the narrative right and to decide on the steps that are needed to be put in place to stay ahead of the pandemic, ahead of the virus, assessing the capacities and building the resilience while transitioning from the crisis management to the recovery management. Saying this, systems, including the health systems, need to be restructured to accommodate the urgent, medium, and the longer term concerns. 3 months from now, 6 months from now, maybe even longer, 1 month, 1 year and beyond. We need to have a new vision with clear government strategies. We have learned a lot, and much is still to be learned in the coming days, months, and years. However, we have learned several things from the experiences on the global, regional, and national levels that we have to build upon. So what have we learned? We have learned that the virus isn't going away in the foreseeable future until either we have herd immunity, which is achieved either by infection or vaccination, and both to occur, this needs much longer time. We have learned that health systems cannot on their own overcome or solve the existing or evolving health challenges, and that we need stronger health systems that are resilient to shocks and essential services, and that the essential services are much disrupted. We need strong health security, public health, and universal health response plans. We need to be embracing the whole of the government and whole of the society. And this cannot be achieved unless people's health and well-being are prioritized developmental framework. People of all ages, they remain susceptible. Countries, and this has been the done. We know that many countries have succeeded in suppressing the transmission of the virus by undertaking the right precautions and the right interventions to contain this virus. We have learned as well that the essential pillars of the containment are known, and they have proven their success: testing, isolating, treating, contact tracing, and quarantining. We have known that death can be reduced by protecting the vulnerable groups, and the vulnerable groups are already much known to us: elderly people, those with non-communicable diseases, the healthcare workers, essential workers, the poor people and poor communities, and those where inequalities exist. We know that the communities have the role to play in distancing, in hand washing, in cleaning hands, practicing respiratory etiquette, wearing masks, and avoiding closed spaces, avoiding crowded places and closed contact settings. And as well, we have known, as have always been mentioned by the DG and other professionals, that the national unity and the global solidarity is a benchmark for the response. We have to do it all, and at the same time, we have to avoid the single action approaches. So what does it take to have this sustainable, integrated response? Governance structures have to be organized around a number of actors from the state and the society through a synergistic set of adaptable policies, resilient structures in the sectors, and with processes that support the foresight and the collaboration that we need people's engagement and emphasizing the role of the society as well. We know and we learn that the stronger investment of public health and in health workforce are essential pillars for any response, while harmonizing sectors with different strategic approaches towards enforcement of the national emergency, public health, economic, and the social response. It has been mentioned and reported that more than 172 countries are now engaging with the COVAX facility, which is the largest and most diverse COVID-19 vaccine portfolio in the world. This will enable the mechanisms for a globally coordinated rollout, ensuring that all countries receive the vaccine in an equitable and a timely fashion. And also the response revolves around decisive and adaptive leadership, and that the coordinated response will lead to a comprehensive impact. Actions are undertaken to generate evidence, develop treatments and vaccines, but still, as have been mentioned by my colleagues, much is still needed to be known and to be learned. Success could be reached, and we know this from the experience from many of the countries, and we need to succeed. There is no room for failure. And so transparency, communication, leadership, and the public health are key pillars. So what should be done in the foreseeable future? Governments are now transitioning from the crisis management to the recovery management, with an opportunity to restructure the health systems and their functions to be fit for an envisioned purpose. We need to know our purpose. We need to utilize innovative ways of analysis, thinking, data generation, managing, communicating, and governing to strengthen the health systems, reshape the plans, strengthen the public health functions, support institutional capacities, and partner with all stakeholders, having health security as a cornerstone of all response. And we need finally to acknowledge the fact that there is no going back to business as usual, and that health on its own is a developmental priority. So governments must take the rapid steps, rapid actions to assess the effectiveness of the response, to assess the effectiveness of actions that are needed in the future to promote the policies, the regulations of protecting health and the well-being. What is really important is that all governments should have the commitment to change for innovative, resilient, fit-for-purpose, adaptive arrangements that at the same time promotes the integrated and adaptive collaborative actions of health and non-health sectors, communities as a partner in all of the response for a new shared vision to develop new set of governance arrangements that support coherence, adaptability, and flexibility on the global, regional, and on the national level. Thank you very much.
Thank you, Excellency Professor Maher Rabad, for the very interesting presentation and talk. And actually, among your talk, there is very important message. We should have sustainable integrated response to success, and failure is not a choice. We have to restructure our health system and support institutional and individual capacity. But what makes us a little bit desperate that there is no going back to business as the old normal. So this is a message from Professor Rabbar. Thank you very much. And by the way, I would like to thank Professor Bertha for the active communication with our attendee on the chat platform. And now we would like to have more elaboration on the experience of Al-Azhar University in managing COVID-19 pandemic. And now, Professor Mahmoud Siddiq, the Vice President for Postgraduate Studies and Research, and also the Supervisor of the hospitals, academic hospitals of Al-Azhar University. And we have 6 academic hospitals distributed all over the country. He will elaborate for us now the experience of Al-Azhar University. Welcome, Professor Siddiq.
Thank you very much, Professor Amani. Thank you, Professor Maha, for nice presentation. First International Pharmaceutical Medical Science Conference, Azhar Hospitals and the Management of COVID-19 Crisis. COVID-19 pandemic has impacted hospitals around the world. Patients served by the hospital are affected. Many health facilities closed or limited services. Physical and psychological consequences among healthcare providers: lack personal protective equipment. WHO stated that 1 person among health workers is infected. Al-Azhar University, associated with Al-Azhar Mosque in Islamic Cairo, it is Egypt's oldest degree-granting university. In addition to higher education, Al-Azhar oversees a national network of schools with approximately 2 million students, 86 faculties, 19,000 faculty members. Al-Azhar Medical School graduation 2020. Al-Azhar planned during crisis, creating a crisis management committee, apply strict quarantine measures, disinfection of all buildings, following the precautions and the preventive measures taken by the hospital, solving all the problems once they appear, training of healthcare workers, medical staff, house officer, and residents, training of healthcare workers for 3 weeks, 1,400 doctors, house officers, residents, associate lecturer, and professor, and 300 nurses, providing increased access to personal protective equipment, providing psychological support, routinely conducting hospital surveillance, recognizing health system gap, implement updated protocols, screen everyone entering the facility, and to identify and track suspected cases and contacts, applying appropriate quarantine measures and physical distance, practice hand hygiene and frequent disinfection of departments. Al-Azhar University hospitals include 6 hospitals between Upper and Lower Egypt and Cairo, Al-Azhar University, Al-Hussein University Hospital, and Sayyid Jalal Zahra in Cairo, Dumyot in Lower Egypt, and Asyut in Upper Egypt, and one specialized hospital, Azhar University Hospital. On 20 April 2020, the university president decided to convert the hospital to an isolation hospital to serve affected patients who belong to Al-Azhar University. Hospital division, 4-floor, 350 isolated single rooms, 50 ICU rooms, radiology department, lab section, and pharmacy. And 4 guarantee separate hotel include 96 single rooms, university city buildings, 80 rooms, and kitchen. Time frame. First cases was admitted on 22 April 2020, and last case was discharged on 13 August 2020. For statistical analysis, total patients, 330 patients, which include 176 male cases, 154 female patients, and 17 patients was admitted to ICU rooms. 308 cases completely cured from the disease, 93%, and 20 cases was died from the disease. Between age of 0 and 40, no cases was died from the disease. Between 40 and 60 years, only 6 cases. Older than 60 cases, 16 patients, and male patient 20, and 2 cases were female. 0% infection among medical teams who managed the admitted patients to Al-Azhar University Hospital. The Azhar management during student exam, complete separation, distance, and wearing mask, continuing medical service to other COVID patients, and social education to contain COVID-19 pandemic. The Azhar role in helping government and receiving stranded people from abroad, 3,175 people, 3 waves, each 15 days of quarantine from 9 April to 23 May 2020. The Azhar medical teams, 4 teams to Al Aguza Hospital, 4 teams to Sheikh Zayed Hospital. Till today, 8 teams to Abu Teeg Hospital in Upper Egypt in Asyut. Each team composed of 10 doctors, 2 internal medicine, 2 chest, 2 anesthesia, 2 cardiology, radiology, and clinical pathology. Medical committee service never stopped during crisis. Thank you very much.
Thank you very much, Professor Siddiq. And as usual, Azhar University pioneer in healthcare services for all Egyptian community. And now it's time for question and answers. So if anyone would like to write a question for one of our honorable speakers, just write it or raise your hand to give the question live.
حضرتك في اسئله شفناها موجوده.
طب لو حضرتك ممكن نعم.
شفت واحد.
If you can answer it right now, Professor.
حاول كده استرجع معلوماتي او
Okay, thank you.
وانا شفت سؤال question على البوست انفكشن symptoms.
Yes.
And this point is very important point. Already I'm asking this question because I'm just a physician and also I manage patients in critical care, and post-infection symptoms and we define as post-COVID-19 syndrome.
ممكن تقربي له اللابتوب؟ قربي له اللابتوب عشان
Some cases are psychological upset after severe respiratory infection and respiratory distress. But some cases are related to some pathological, radiological changes in the lungs, which is ground glass appearance, patches of pneumonia, and persistent interstitial lung disease. And this is one of the causes of shortness of breath after COVID-19 infection. We treat, and this also is recorded more in patients with underlying lung disease, chronic obstructive lung disease, asthmatic patients, or smokers, etc. So that we recommend to use symptomatic treatment in the form of bronchodilators, but we recommend for gradual tapering of high doses of systemic corticosteroids, methylprednisolone or prednisolone. We started with 30 milligrams per day for 10 days, and then with tapering the doses of corticosteroids, and there is some improvement, but the changes in the lungs, the radiological changes, and the shortness of breath sometimes persist for a few months after the infection with COVID-19. Thank you.
Thank you. Any comment, Prof. Maha? Can you, any feedback and comment, please?
No, I'm just saying that the questions that Dr. Awad might be able to answer. Someone was asking about the recorded percentage of recurrent infection.
Yes.
And the doses of remdesivir.
معلش طالما ما انا ما سمعتش يعني.
The first.
Percentage recurrent.
سؤال كويس. Up till now, there is no evidences. تقصد reinfection. There is no definite recorded cases of recurrent infection after resolution of the first infection. But yesterday, I heard about one case, one report about reinfection with COVID-19.
Oh.
But definitely, there is no data about the solid immunity after infection with COVID-19. So that the possibility of reinfection is definitely is one of the possibility for COVID-19. So, but up to now, there is no evidences of recorded cases, even either in the international literature or in the Egyptian literatures. So that we must wait and follow up the cases for any possibility of reinfection.
When many studies now are undertaken all over the world to assess to find out the level of immunity post-infection and how much time does the antibodies remain and the immune system is present and is able to protect those who are infected. So much studies are still underway to assess this, and definitely some of the studies have mentioned that the immunity stays.
So the issue is that immunity is there after infection. It's the duration of this immunity and when does it wane. This is the type of the studies that is being undertaken now in many countries and for many patients and even in community surveys, and it is there for some time. However, the duration is still under question, and that is why when a reported case has been mentioned of a reinfection of COVID-19 that was even severer than the first case of infection. So this is one case study that has been reported recently in the past week. So we need to wait and we need to carry out all the studies later on and to continue with those studies to understand the immunity pertaining to the infection. Thank you.
So, Prof. Rabat, there is a question: if reinfection in a short time is a possibility, how could a vaccine be effective? or it could need booster dose administration?
These are the issue of the vaccine is still
Under trial?
under trials, and
Yeah.
now we have like 9 vaccines in the third phase, or in the clinical trial phase. So much needs to be learned about the effectiveness of those vaccines, the doses of the vaccines, the time of the immunity that they provide. But definitely, we all know that whatever infection is there, the immune system has a memory that brings out the immune system.
مش باين.
These are things that needs to be
وحشة
studied
فيها.
during the time that we're having those studies and those clinical trials.
Okay. Bro,
السؤال بتاع الفاكسين، لو احنا بنقول
if reinfection.
لسه بندرس الاميونيتي اللي بتحصل والفاكسين، طيب ازاي هنضمن ان هو هيدينا الاميونيتي المظبوطه اللي هو هيبقى محتاجين 1 دوز او 2 دوزز او ايه عشان خاطر نقدر ان احنا نعتمد على الفاكسين كوسيله للحمايه من المرض، من الانفكشن.
طبعا more than one machine, but the expectation or the vaccines already in phase 3 clinical trial, which is clinical human trial, is about 7 to 8. عايز اطمنكم ان احنا already from the first اول ما اعلن عن اول vaccine we started to make communication with the national society or alliance for availability of vaccines.
بس بعد السؤال ده.
Now, most of the vaccines are in phase 3 on the human trials and for the effectiveness and the safety of the vaccines. As Professor Maher mentioned, we will know after the end of this this vaccine is 1 dose vaccine or maybe 2 doses between each dose 1 month, and for how long the vaccine will be effective. And most of the viruses, maybe 30 viruses,
يا دكتورة.
there is mutation and some changes in the gene sequences of the vaccine. Up to now, there is change already. There is change in the spikes, which is present in the vaccine, which is the effectivity of the vaccine is usually مفتوحة. طلع العيب مش من عندي. Still the vaccines are under trial, but definitely whatever the effectiveness of the vaccine, 70%, 80%, or even 60%, it will be of value.
I think after hours, if it is above 50%, I think it's going to be of value. Even
طبعا, it will be of value. And I mentioned it will be of value. Hello? تفضل يا فندم.
There is another question from are required to reduce complete viral load. Dr. Siddiq, is this a question related to you? Till we got the answer for the question, we would like to thank the efforts of Association of African Universities for providing us this platform and also for broadcasting our conference TV. Prof. Awad, there is another question. How many doses of remdesivir are required to reduce the complete viral load? How many doses? Yes. It's individual variation, maybe? And the load of viral infection?
listen for a few minutes.
Yeah.
The main value of the drug, it is effective to shorten the period of conversion to safety or period of hospitalization by 3 days. Only by 3 days. It is up to now, this injection drug is used for severe or critically ill patients, and patients from 5 to 7 days. It is twice daily doses for 5 to 7 days. And as I told you, it is only valuable in severe or very severe patients, and its value may be some improvement in some cases, and quick or more conversion of the positivity. نعم. الدوز بتاعته في الفايل فيها. تقصدي الدوز ولا كام؟ for how many days؟ الدوز الفايل I think في 200 مللي جرام.
Okay. Prof, there is many questions, and I suggest if we can gather all these questions and you answer them, and we hang the answers on the website of the conference later. Is this okay with you, Prof? To collect the questions and answer them and raise it on the website of the conference as a Q&A partition in the conference later on.
لا دكتور عوض.
لسه كان معي.
عشان الأسئلة كتيرة بس.
Yes, because we have many questions and we would like to share the experiences of our honorable speakers.
Yes.
Okay. We will collect all questions. So, Prof. Mahrasawi, we close to the end of the session. So the mic for.
شكرا معالي الوزير، شكرا معالي الوزيرة، شكرا للسادة المداخلين والسادة الحضور. والآن نرفع الجلسة للاستراحة لمدة نصف ساعة إن شاء الله. شكرا لكم على هذا التفاعل والتجاوب.
Thank you. And the second session will start at 5:30 p.m. Cairo local time, 3:30 GMT. Thank you, all our guests, and see you within about 1 hour. Goodbye.